Welcome back to Brighter Morning with Bo. I am Bo Tiwari, your host, and I'm glad that you're still with us and that we will engage a new subject. We were just talking with Professor Patrick Watson on what we consider the cabinet might be usefully focused on. And he mentioned two things. One, not to take the recent IMF gift or any part of it and dedicate it to the deficit. Secondly, be judicious in the reduction of subsidies. And three, fast track growth of exports and some initiatives on innovation, and begin to initiate some longer term sustainability initiatives that could make a difference in export growth, diversification, and sustainability. Those were the things that he mentioned. We go on now to two very distinguished gentlemen, Professor Teelucksingh, who is a professor of medicine, a specialist in internal medicine at the University of the West Indies. And we also have Dr. Sirjusingh, who is a senior official at the Ministry of Health and a director, in fact, at the ministry. And we are going to be discussing with them some issues related to diabetes. And as you know, diabetes is one of those things that we hear all the time with these COVID deaths. You hear about comorbidities, and we have a diabetes epidemic in Trinidad and Tobago, you might say, and throughout the Caribbean, really, and it is becoming a very problematic disease in countries almost everywhere in the world. So we'll be doing some talking about that, and we'll have these very knowledgeable gentlemen speak about it. Okay? So are they on the line now? Well, let us bring them on and welcome them, both of them. Professor Teelucksingh, good morning.
Hi, good morning to you.
Let's raise the volume so we can hear them better. And Dr. Sirjusingh, thank you so much for coming here.
Hi, thank you.
Dr. Sirjusingh is the Director of Women's Health at the Ministry of Health. I've heard him on occasions on radio, very, very clearly articulating his position on so many issues and making positions very clear that any ordinary person can understand. And I know Professor Teelucksingh for a long time. He takes very, very complex issues and finds very funny ways of making them clear in the minds of ordinary people. So he's a good teacher that way. So we will engage them this morning and have them talk to us about diabetes. I will ask you, Professor Teelucksingh, if you would start by framing our discussion this morning.
By all means, thank you very much for having us, Bo, and I'm delighted to be sharing the podium with my colleague, Dr. Sirjusingh. So, diabetes is really the world's first great pandemic. Unfortunately, there's an end in sight to the increasing. There's been in Trinidad for the last 60 years. Probably a little longer, but the first documented study and that which emphasized the scale of the problem here was first published in the early 1970s. The work was done in the 1960s. And I speak of course of the preeminent researcher's work, Dr. Teelucksingh, who highlighted that Trinidad had the highest prevalence of diabetes in the Western Hemisphere at that time. And we continue to hold a #1 ranking for this disease in the region. So much so that 1 in 5 of adults above the age of 20 will have the disease, and 1 in 4 above the age of 40. So it is indeed highly prevalent. And the consequences of it, everybody is well aware.
Okay. Now, there are ways of treating and managing diabetes, and when you go to your doctor, the doctor would prescribe various ways, and the main thing is to kind of control it by a mix of medication, if you can, and also by diet and exercise. Generally, the doctors would give you that kind of advice and take that kind of approach. And you can have, of course, more serious cases. But I think one of the things, any thinking person might be concerned about is, can we take a preventative approach to this? Can we somehow find a way of eradicating or eliminating this? Or if we cannot, what approach can we take to basically reduce the risk factors and mitigate against the high prevalence that we now have as a country in Trinidad and Tobago? Could you address that a little bit, please?
Yeah, I like to say, and I do genuinely think that we're living in the best of times and we're living in the worst of times. Amidst the backdrop of an expanding disease and us being engulfed by this major problem, there's a great deal of hope. And today we can talk of diabetes remission and diabetes cure, which is really, really visiting. That's something we couldn't speak about before. And there's now before a method to reverse diabetes and methods to essentially cure it. And to understand that, we must understand the genesis of the disease. Diabetes doesn't exist in isolation. It comes as part of a greater package. Unfortunately, that package includes hypertension, raised cholesterol, a propensity to gout, an ultimate propensity for the large and small blood vessels in our body to become inflamed and obstructed, leading to blindness, kidney disease, limb gangrene, strokes, heart attacks, and so on. That's the bad news. The good news is that there's one underlying tenet for all of these diseases, all of them that are packaged together, and that's obesity. And the strategy, therefore, is to target the underlying Achilles heel, as it were. If we were to able to address obesity in its own right, we hit the whole gamut of diseases simultaneously. And therefore, in today's world, treating diabetes is treating obesity. And when and if we control obesity, we can allow diabetes to remit or be cured.
How could we do that, starting with children, for instance? I think when I was at the university, we had talked about that, and you had initiated some things. And I know that there was a researcher whom we supported, Yvonne Batson, who had done some work in the schools to try to assess what was the prevalence of diabetes in young persons. Can you take us back there a little bit, just for a minute, and take us forward to what is possible now?
Yeah, so you're quite right. The link with obesity is so strong, and that's explaining why the prevalence of diabetes is increasing here and worldwide, because the world is getting fatter and I don't use that term pejoratively, I'm using it simply for descriptive purposes. As the world gets obese, more obese, diabetes is going to follow in its wake. And that doesn't matter whether you are 5 years old or 50 years old. If you are overweight or obese, the risk of diabetes increases many, many fold. And 20 years ago, we had observed in our clinical environment an increasing number of children who were developing the type of diabetes that their grandparents should have. And indeed, that's what Yvonne Batson studied. She studied obesity in school children and the consequence of diabetes amongst them. And this is what she found. In 2001, she found a background prevalence of about 11% obesity in school children. 10 years later, she studied the phenomenon again, and that had increased to 33%. 2 years ago, we had the opportunity to take a fresh look at our school kids, and that had increased to 50%. Now, just think about those numbers for a minute. 20 years ago, 11%, 10 years ago, 33%, and currently 50%. And I want to make a proviso here. This measurement assumes that our standards are equivalent to international standards. So if we were to measure with the same tape measure here as we do elsewhere, it's 50%. But I'd like to say that there are ethnic differences in obesity. And people from the Indian subcontinent express diseases due to diabetes at lower thresholds. So if we were to consider that, more than 50%, I would say 60 to 70% of our school children are overweight or obese. And this is what is driving the obesity epidemic in young people. Unfortunately, the earlier the onset of diabetes, the more vigorous the disease, the more aggressive its course. So really, we're sitting on the horns of a dilemma. And you're right to ask what's the next question and how can we really tackle this issue. That's where Dr. Ade's Sirjusingh is in. When our research team were faced with this dilemma, and we were finding young children in primary schools and secondary schools with type 2 diabetes, we came upon a strategy, one that's based on evidence. We know that a baby that grows up, the embryo that grows up in an environment of raised blood sugar, is more likely himself or herself to reveal her diabetes earlier in life. And we thought it would be a good idea to try fixing diabetes in the womb. And that's exactly why Dr. Ade Sirjusingh and our team and the Ministry of Health got together with this pretty aggressive approach to managing diabetes.
All right. You want to take it from there, Dr. Sirjusingh, and tell us what is being done and how it is being done through the Ministry of Health?
Yeah, excellent. Thanks for the opportunity on behalf of the Ministry of Health to share with you and your audience this program. And of course, Paul gave a lovely introduction and background to diabetes and the approach. So in 2016, the cabinet would have agreed to an IDB project. So a loan was signed off targeting NCDs in general, and this is one component of the project. So at that time, basically the incidence, we had found that at some stage of your life, 60% of our patients in Trinidad and Tobago had some non-communicable disease, which includes diabetes, cardiac disease. We found that, in these patients, 33% of them were dying before time, premature deaths, it was called, with obesity running through the entire.
Are these, I didn't get you clearly there. Do you mean the general population? Do you mean the female population? Or do you mean the pregnant women's population?
Yeah. So this is just the background of the whole project. It's actually the population of Trinidad and Tobago. My part is part of the wider project.
Yes.
It's called the Health Sector Strengthening Program to target the NCDs. So there are different limbs of the project, and really that's the background with respect to where we are. So this novel project is really about diabetes in pregnancy. So my component really is about strengthening different aspects of it. And I'll actually go forward back a bit to what Paul said. So he's saying that we should be targeting our pregnant mothers and looking at the babies in the embryo. So actually, the project starts even before that. It starts with targeting the population who are in the reproductive age group to get them healthy to have the right choices before they even become pregnant. We
Okay.
want to go back a step so
Very
that these
good.
mothers, when they enter pregnancy, will be healthier, they will be less obese. If they had diabetes pre-existing, it will be well controlled. So we have to go back a bit. Some of them, in fact, need contraception to ensure that they have a healthy outcomes until they're ready to have that baby. So it's actually, we have to think way beyond what we traditionally thought
Sure.
about being doctors and targeting diabetes. Prevention really is the first part of
Yes,
it.
okay. I like that. Go ahead, please.
Yes. So this project really is about my role at the Ministry of Health. So it's called the Directorate of Women's Health, and we were formed in the year 2017. I'm an obstetrician and gynecologist. I also have a lot of administrative experience, management experience. So that's how I came into this post. It was really formed to target and reduce and improve actually the outcomes for mothers and babies. So this really fell right into my lap, and I was really happy that it did. It gave me an opportunity to build on some of the other projects that we are doing at the Ministry of Health. So it's about, first and foremost, of course, standardizing things. So we were able to start standardizing the way we diagnose diabetes in Trinidad and Tobago. This was something we didn't have. We had at the Ministry of Health, we were able to create standardized clinical guidelines so that if you're in Toko, if you're in Scarborough, if you're in Moruga, you'll be diagnosed the same way by all the clinicians singing from the same songbook as it is. So patients now no longer are the whim and fancy of your training, where you may have trained in the United States, in the UK, etc. You all are using WHO standards to diagnose the diabetes. We have standardized the way. We have actually put something in place where every single patient gets tested for diabetes twice in pregnancy. Before, you were based on risk factors, we were testing for diabetes. So we were missing, probably, all know those figures, 50% of cases we were probably missing that way by selective screening. So now every single client who comes to the system gets tested for diabetes twice. And we are picking up diabetes much earlier now as a result, and able to put things in place, the clinicians, to help improve outcomes. The project is not just about the clinical side. We had to think wider. We had to look at improving, of course, the technical capacity of the clinicians, the midwives, the nurses, everybody who deals with diabetes. So we have a learning component. We have a lab component where we are strengthening the lab. We have an ICT component where we are linking things together. We're linking the lab with the patient medical records and the clinician, so you can make changes much quickly. We have a number of exciting things to do with accreditation of the laboratories as well. We also have a communications platform that's coming soon to let awareness programs are coming, so patients will be better educated. That's the next phase of the project. So it's a two-year project. And by October, we'll be at the halfway stage. But in the next few months, you're going to see lots of exciting things being rolled out. One of the things to look out for is that patients will actually have their own devices to take home if they are diagnosed with diabetes. So these modern devices will use modern technology so that these patients, when they test it for their sugars at home, it will be seamlessly uploaded through the cloud into their patient files. It will be linked to the hospital's notes. The clinicians will be linked. The patients will also get alerts in case they need to see their doctors earlier. So you can immediately see some of the benefits right there.
Okay, this is very good. Let me just kind of itemize some of the issues so that the person listening or hearing, hearing or viewing will get a sense of what's happening. We had these early studies in the school system which showed us that the predisposition to diabetes and the actual carrying of diabetes was increasing in the school age group in Trinidad and Tobago, and it moved from 11% to 33% to 50% in 20 years. And you are saying ethnic factors taken into account could take that as high as 60 or 70%. Then, following that, we also know from the information that the earlier you get diabetes, the more problematic it is. So a preventative approach was taken. How can we deal with this? To get to diabetes very early and try to, first of all, prevent it, and secondly, once we find it, to manage it better. Dr. Sirjusingh is telling us, basically the Ministry of Health now is taking an approach which looks at women generally in the phase of their life where they might enter into reproductive life, and basically targeting them from a testing and preventative point of view, and then managing that so that you can then manage the pregnancy and manage the unborn child in the womb, and then follow what is happening to that child, and that you are using technology to do that, and you've standardized the system throughout the health system. Now, I have to ask this question, and which is that, Dr. Sirjusingh, what you are doing is talking about the public health system, the hospitals, the health centers, etc., throughout the country. Is there a connection between that and the private system in Trinidad and Tobago so that we capture the entire population?
Oh, yeah. Oh, yeah. So that was actually one of the first things I did in the first year, was to establish connections with the private sector as well, because the Ministry of Health is concerned about the entire public, not just about the public healthcare system.
Right.
So approximately 91%, 92% in any given year of patients actually encounter the public healthcare system and deliver in the hospital.
Sure.
Just a small percentage will end up delivering in the private healthcare, but of course they're seeing their private healthcare practitioners, their GPs, they're going to health clinics, they're going to specialists as well. So we had to find a ways of breaking down those barriers and linking everyone. So these projects target both sectors. And to link everything together, we actually had an initial project called the Perinatal Information System, which is a way of standardizing antenatal care. I started working on that project way back in 2015 with the Pan American Health Organization. And this project actually intersects this project that we're doing now, where all our pregnant women in both the public and private sector have a standardized way of, like a checklist system. We've kind of simplified it so that everyone will have a similar way of getting care. And in the public healthcare system, in two of the RHAs, the Eastern Regional Health Authority and in the Tobago Regional Health Authority, that system is actually already in the electronic version, where when you encounter the clinician, they actually use the computer first, which is novel. And when you come to our system, you'll be amazed in the public healthcare system to see the doctors typing up the information, doing everything on the computer first, and then printing the files. So no longer the traditional paper-based, way of doing things are happening. And now that those notes can be seen from your health center if you enter the data. At the hospital, you can, if you're doing the clinic, it will be seen on the wards when you come in. So no longer will you have problems accessing the notes and so on. And at this project now, when you do your blood sugars and blood tests, they go right into your records as well. So that's how these projects are intersecting, but it's targeting the entire gamut, public and private sector.
Professor Teelucksingh, I'd like to ask three related questions. The first thing is, what happens now to all of this data that is being amassed from the public and private healthcare system, basically on essentially women's health and children's health, and specifically in relation to diabetes? That's the first thing. The second question that I want to ask in relation to that is, how does that information help us in the preventative interventions, let's say in the school system, or have we gotten there yet? And the third issue is that this is very focused on women's health and child health. How do the men fit into this process in the context of diabetes, which is an epidemic in the country?
Yeah, thank you. All really important questions. Well, first of all, I think the public should be reassured that the data that's collected from them and about them will be secure. The systems we are building are termed HIPAA compliant for those who are tech savvy, and that's a standardized way of collecting and storing data. So privacy and confidentiality are assured. The second question has to do what use is the data? Data is the lifeblood for generating protocols, system, and for ensuring that you become better. With inadequate data, you make false suggestions and false hypotheses and you build false systems. So the higher the quality data, the more likely we are to generate systems that perpetuate into fruitful endeavors. And the third issue you've raised, how is this going to impact future generations? Unfortunately, and I'm going to use these terms casually, unfortunately, those of us who have been diagnosed with diabetes have a real heavy burden to carry. But the future is bright in emerging technologies and emerging drug therapy and emerging surgical therapy. So those of us who have the disease have a better chance today than our forefathers of controlling it, and as I've suggested earlier, bringing it into remission or even curing it. Because we understand that weight control is really essential, and we can do that with drugs these days and with surgery. Now, I'm talking expensive options here, and as a public health strategy, surgery and drugs aren't the answers, and that's why Adesha's and the Ministry of Health's project is so very important. We will have a missed generation. We'll have a missed generation of people with diabetes who probably have been spared the wrath of it. But future generations are likely to reap a rich reward from the kind of interventions that Dr. Sirjusingh and the Ministry of Health is making today.
Yeah, one of the questions that you might have not picked up was the question of how will we use this information to follow up preventatively, for instance, with children in schools?
Yes. So you're talking about the gathering of longitudinal data and tracking their outcomes based on their birth weights and so on.
Sure.
Yeah. This kind of database and the kind of recording system that Adesha has alluded to will allow that kind of follow-up. And definitely there's a place for that kind of prospective study. And it will not be new here. I'll just give you an anecdote of how this worked. We now understand, and it's true, that a baby that grows up in a hostile environment in the womb, either because of diabetes or hypertension or infectious diseases, is born at a suboptimal birth weight or a larger than optimal birth weight. In other words, there's a magic birth weight for babies to be born at. And if that birth weight is off center for any reason, you start with a disadvantage. And that was found out during Britain's war effort, the Second World War, where an epidemiologist started to collect data on birth weights because he wanted to see if birth weight could predict who would be the best soldiers to fight in the British Army. That's the reason why the data was generated. And when somebody in the 1970s and 80s looked at that data set, they were able to answer another question. They found out what the optimum weight for optimum health was. So a roundabout way of answering your question, how data helps us to understand biology and to make plans for the future, is given in that anecdote. So you're right, by collecting high quality data today on our nation's children, we'll be better able to predict what's optimum for our nation.
Okay, well, the data on the children will be both sexes, male and female, but the data that you're getting on the mothers is female data only. How do you bring male data into the national system?
Yeah,
yeah.
Adesh?
Yeah, maybe
Adesh,
I
you
could
want
just
to
interpose a little bit. Of course, there are strengthening systems across the board outside of this Women's Health Project.
Yes.
So we are looking at collecting data and so on across the board for both males, females. That's part of the larger strengthening that we are doing. So, but I could still go back a bit towards the pregnancy issues and how the data probably is already helping us.
Sure.
As I said, coming into this office in 2017, data and lack of data was an issue as we had to target and improve maternal and newborn outcomes. On any given year, we had 10 to 12 mothers dying, for example, from all sorts of causes. But we were able to collect data quickly, analyze it, and make targeted approaches and help quickly bring down the maternal morbidity and mortality way down to, and we have actually reached international levels as far back as 2016 and moving forward every year. We have been meeting the Sustainable Development Goals 2030 for that area. And similarly, in diabetes, for example, coming back to the topic, we know that poorly controlled diabetes leads to a host of complications with the babies while they're inside of there, including stillbirths, including congenital abnormalities and high blood pressure in pregnancy and so on. So the data that we are receiving, which is very rich data, is showing, and we still yet have to analyze this fully, is showing a significant reduction. The benchmarks are neonatal mortality at the end of the day, and neonatal mortality rates have plummeted since the last few years, where we are now at 7 per 1,000 live births, less than 7 per 1,000 live births on any given year, which represents overall 80 to 100 babies being saved, not only from diabetes, of course, 80 to 100 babies per year who are alive who might not have been. And similarly, we're down to less than 3 women per year who are dying. So another 5 to 7 women are being saved in any given year. So that's how the data is helping us. In years to come, this is a lifelong project for the future generation, actually. We are building things that you can look back. So when someone comes, your great-great-grandchildren come, they can look back at your forefathers' records and see where, hey, they had gestational diabetes or they had this condition. Their records would be available in a sense. You're paying this forward in this project. Sometimes we see, very quick gains, and we like to talk about these quick gains. But I think Paul and I, our teams are looking at these long-term benefits in this project.
Yeah, well, we've got to make the quick gains, but I do believe in the long-term strategies. If you're talking about a nation, if you're talking about a people, the long-term strategies are critical. But let me go to another issue now. Many of the COVID deaths, we have this horrible epidemic that nobody anticipated would have the kind of effect that it has been having on populations everywhere. And a lot of the people who die from COVID are said to die because they find themselves in a worse position because of comorbidities, of which diabetes is a principal element. Could you talk about that a little bit, Professor Teelucksingh, and tell us a little bit about what is happening to the extent that you are aware of this?
So I describe diabetes as the world's first great pandemic.
Yes.
And diabetes, of course, is a chronic disease. And we're seeing the interplay between an acute infectious pandemic and a chronic pandemic. And not surprisingly, there's huge interaction. The common link appears to be obesity. Diabetes is the formifrous, the superficial appearance of underlying obesity. And people who have COVID and have obesity at very, very high risk, here and elsewhere. So in the UK, for example, with a pretty diverse ethnic and rich ethnic mix, it was found that people of the South Asian extraction were more likely, and people of Afro-Caribbean origins were more likely to die from COVID in their first wave. And lots of factors and forces may be at play here. They were likely to be socioeconomically lower in the ladder than say, white Britons.
Yes.
Or they may have place exposure. But in the end, they showed that there's a clear link with obesity. And of course, where obesity leads, diabetes follows. Okay. And it's not only true that people with COVID suffer badly with obesity and diabetes. That's true of the annual flu. When the annual flu goes around, people with pre-existing diseases are also picked out. So it's nothing unique to COVID.
Okay.
Essentially, it's the straw that breaks the camel's back. The more disease burden you're carrying, when you've got an additional one, you're more likely to succumb.
It's a problem, yes, it makes you more vulnerable. But let's deal with this question of obesity because that seems to be the real problem. How do we deal with that in a society such as Trinidad and Tobago? And I suspect education has a lot to do with it. So the question that arises is, first of all, how do you educate parents and children so that they can address this question of obesity from the point of view of diet and exercise? Do we have any strategies for that, Dr. Sirjusingh, within the public health system?
Oh yes, certainly. There are a number of things that are actually happening, one of which would have happened already prior to the schools being out, would have been the cessation of sweetened beverages in schools, which was one of the very first things that we did to ensure that was happening. However, now that children are stuck at home, that has probably gone out of the window, where children are living in their refrigerators and bad habits are reset. So that was the first approach. There are many ways where we intersect. There's actually the RHAs, for example, have school health visitors and nursing staff who encourage healthy education. And so there's the curriculum development. There's a health in schools policy where this is promoted as well. That's work in progress. In addition to that, as part of even this project that we are doing, I'm hoping to influence the communications and public awareness campaigns. So it's not just about diabetes and pregnancy. The spin-off will be to promote good health and lifestyle changes and all of the important things. The ministry has also put things like, for example, we've established a number of gyms in the health centers and different places as well. So that's also happening in the background. I know COVID is in the front of everything. The gyms are there as well. We do have nutritionists attached to hospitals promoting this as well. We do lectures for all our pregnant women and, of course, the pediatric age group as well. So there are targeted interventions and then generalized communication strategies that are ongoing. But as you know, it's a work in progress. Education is key to it all.
When somebody goes to the health center for whatever problem, whether it's diabetes, hypertension, they're not feeling sick, they're not feeling well, or whatever it is, are they spoken with on issues of diet, for instance?
Absolutely. I can just say I have some relatives of mine who attend the Makoya Health Center. I know they're listening in, and they can say from their own experience that it's a overall thing. It's not just about meeting the doctor at the day. They are also spoken to sometimes by the nurses in charge of the clinic. The pharmacists also give out advice, and there are nutritionists as well. They get fact sheets and information to take home. So they always talk about the experience they had. It's not special treatment. It's a walk-in service. They're well attended to. And this is the norm that happens on a daily basis across the public healthcare system.
Professor Teelucksingh, we're coming close to the end now, but what are some of the simple, inexpensive things that people can eat that would be good for them in terms of not gaining weight? And what are some of the things that they should avoid that are easily available, but you should avoid them, that would help? Let's say you had to eat 2 decent meals a day, and you had to maybe do a little snack in between or something like that. What would that be?
So, if I were to simplify this in 1 or 2 lines, I would say the following. It is, first of all, a complex issue, and
I know that.
That's
why.
It's a complex issue, it's a universal issue, and there's no quick fix. But the general rules of thumb are: 1, small meals regularly, snacks in between your meals, and those snacks should be fruit and or nuts. Avoid prolonged starvation, because that's when you go into savings mode. Regular physical activity meaning 30 to 45 minutes, minimum 5 days a week. Adequate rest and relaxation, and being in a healthy environment. Those are the tenets of successful health.
Yeah.
Let me summarize them. Small, frequent meals. Snacks in between your meals. Those snacks could be fruits or nuts. Avoid prolonged starvation. Now, when I say that, 1 meal a day may not cut it, because then the body goes into starvation mode. It's better to divvy that up into a number of small encounters, and then the metabolism is more likely to be receptive. Having said that, there are all kinds of fad diets and ketosis-prone diets and a whole host of other things that people experiment with. And it's good that they're experimenting. You have to find a formula that works for yourself. But I'm afraid there's no quick fix for this one, Bo.
All right, okay. I think I could even summarize it further. Eat less and exercise more, and eat in small quantities. Anyway, I want to say what a pleasure it has been to talk to both of you, Professor Teelucksingh, Paul, and Dr. Sirjusingh, because here it is, you are working on something that is a real problem in Trinidad and Tobago, and indeed in the entire region. And it's a worldwide problem now. Even the wealthier countries are becoming even more, what can I say, susceptible to diabetes and related diseases. So first of all, you are doing something that matters a lot to a lot of people. Secondly, you are providing knowledge, and you are providing solutions, and you are providing key interventions in the public health system, and you are providing good medical care and good medical advice. So I want to commend you on that and thank you very much. And I thank you very much for appearing on this program. Maybe on another occasion we can carry it further. But this is an important exercise. And let me say today to the listenership, the viewership that is looking on or hearing this morning, that the key thing is to, I mean, as Professor Teelucksingh is saying, is to keep your weight down, and to do that by not starving yourself or going on any fat diet, but, you know, eating small quantities as regularly as you need it, and trying to stay away from the fatty stuff. So when he talks about snacks, he says eat a fruit or eat some nuts. So if you manage the weight situation, you will manage a lot of other things. And that is the best thing that you can do also for your kids. Because when you do that for your kids, you are giving them life, you are giving them opportunity, you are giving them health. Okay? So thank you very much for being with us this morning, and maybe another time. Okay? All
Yes,
the best.
indeed.
Thank you for having us. Yeah.
Thank you.
Yeah. All right then. Bye. Well, that was a really excellent discussion here this morning. We move on now to the news with Andrew Chan. We will go on to the news. This is Brighter Morning with Bo. And I am Bo Tiwari, signing off now so that Andrew can come and read the news. Remember, you learned something this morning from two very distinguished doctors in the system, one from the private sector, one from the university. That's to say, private sector and university, but also one from the public health system, and you understand what is happening here now. Okay? So, thank you very much for listening and watching, and we pass on to Andrew Chan and the news.